Welcome all. Today's talk will be on the approach to new onset fever, which is the common day problem which we face every day in the ICU for a ICU doctor. So, how to approach the new onset fever in Indian scenario. So, let's first understand what is fever. So, if we see definition wise, the American Society of Critical Care and the ICCM and the Infectious Societies decided that two records of 38.3 degrees centigrade, which is recorded from the proper calibrated and sterilized site. Either it may be the oral, rectal, axillary or tympanic. Most preferred is the core temperature, which is rectal or tympanic, which may not be accessible to many of the ICUs. So single record of 38.3 plus there is a clinical suspicion of sepsis, that fever should also taken seriously. Of if there is a single record more than 39, that has to be evaluated. There is a caveat: if there is an immunocompromised patient or patient with neutropenia, febrile neutropenia, any sort of temperature, or even if this patient develops say rigors, I will take it seriously without temperature also, and that is a marker of sepsis. So the temperature trends has to be seen in last 24-48 hours, and this is how you define the fever and approach the fever in the ICU. What should I do? So once you have identified, as per this definition, you have got the febrile patient, best is to take the history from the bedside nurse. Now she is the best surrogate relative of the patient. She will tell us about the medication the patient has received in last 24 hours, whether any procedure has been done, whether patient has diarrhea, whether there is a dressing change, whether the catheter was manipulated. So all this important pertinent information can be obtained from the nurse who is dedicated to that bed. Then you review the chart in detail. Always look for the indwelling catheter and central line and arterial line days and duration. Anything which was put in emergency in ER after 48 hours, they is likely to get catheter related infection. And then you should do the focused clinical examination, what we call in trauma as rapid trauma survey. I will call here as a rapid sepsis screening, and that will decide whether you will send the blood culture, two sets of blood culture, anaerobic, aerobic, or you send a particular focus examination. I am against this pan culture is meaningless. So if the patient gets in fever in ICU and your approach of sending sputum, sending the secretion, sending the swab of the wound, sending the urine culture is meaningless. So you have to do a focus clinical examination before sending such cultures. Another important aspect is looking at the drug chart. So many of times the if the drug various drugs like beta lactam antibiotic, antipsychotic, serotonin syndrome, these drugs have been recently started, they may be the cause of fever. In patients with ARDS, fibropleuridity phase may be cause of fever, pulmonary embolism, pericarditis, or in neuro ICU where I work, SAH sometimes can present as a fever, or pontine bleed can cause fever. Whether patient has received IV contrast in last 24 hours, whether you suspect he has abdominal pain, ischemic gut, or in a diabetic patient, immunocompromised, sometimes acalculous cholecystitis or pancreatitis can present as a fever. Now, primarily adrenal insufficiency, thyroid storm, I have not seen primarily as getting admitted as a fever in ICU, but rarely you may get this complication. And always look for the limbs. If the patient has a prolonged ICU stay, always look for thrombophlebitis, decubitus ulcer, hematoma, DVT, or if it's a post-operative atelectasis. So what phase in the clinical context and what was started what was there in the previous 24 hours will give you the clue. And if you are suspecting, your no clinical suspicion of sepsis but the non-infectious cause as a cause of fever. Now this is what I was talking about, the rapid sepsis screening. It has to start from head to toe. So what do you do? If your RT is more than 21 days, look for the purulent nasal discharge, sinus tenderness. Sometimes sinusitis may be the cause of fever, or patient's oral hygiene, parotid swelling, auscultated chest. If there is any new murmur or soft tissue injury and there is a patient suspecting some infective endocarditis, or there is an abdominal examination shows abnormal pain or abdominal tenderness, always turn the patient back to see for bed sores or wound. Look at the indwelling lines and catheters, any purulence in that area. And simple is to raise the see the limb for swelling and wound for swelling, and that may be the first sign clue for DVT if there is a limb swelling. So always do this screening in the patient with fever from head to toe. If you have clinical suspicion, new onset fever, ventilated associated pneumonia, sinusitis, catheter related sepsis, UTI, urinary tract infection, or Clostridial difficile infection with history of loose motion, offensive stool, or there is a complicated wound infection. So these may be the causes of new onset fever in the ICU. So what should be the focused diagnostic workup? So two sets of blood cultures as per the consultation with your microbiology department. Do always the total and differential leukocyte count. The trends will give idea about where our patient is whether landing in sepsis. Now, as far as other investigations are concerned, like imaging studies has to be done on the based on focused clinical examination. Obtaining a chest X-ray, obtaining ultrasound will depend upon whether the patient has symptoms of abdominal pain, CECT, or abdominal thorax if the source is supposed to be occult source. If there is a history of diarrhea, the glutamine dehydrogenase is a very good screening sensitive for stool for Clostridial difficile infection. Echo and TEE if you are suspecting the vegetation and primary murmur. Now coming to other biomarkers like C-reactive protein and procalcitonin, they should not be sent if you are suspecting sepsis. In fact, they are biomarkers may have negative predictive value to rule out sepsis. So when I think of non-infectious cause, I usually send CRP and PCT to support the diagnosis. But if they are positive, doesn't mean the patient has. It may be useful in some studies to de-escalate the antibiotic. Avoid pan cultures. As I said, urine culture most of the time will get pus cell, end up treating a wrong bug and creating antibiotic resistance. Avoid sending urine catheter tips and superficial wound swabs. So once you have identified the source, you know that the line was put in the in emergency. You go for the removal of the central line or in within 72 hours. Stool for toxin or GDS screening. In patient whom you suspect occult abdominal source, you can go for CECT. He may have something to be surgically drained rather than antibiotics. So source control is important in this, and it should be guided by the patient symptomatology. So that's why the investigation should be clinical driven and not should not be protocol based. So removal of central line if the patient has persistent source of fever. If the patient has starting infusion has fever on dialysis, there is a inflammation purulence or there is a bacteremia fungemia. One of the lumen is non-functional, or there is abrupt onset of fever with fulminant shock. So in this you may think of catheter related source of infection if there is no other identified source of infection. Now the big $1 million question is whether we should start the empirical antibiotic. The most important answer to this is if the patient has febrile neutropenia, if the patient has you have a strong clinical suspicion infectious cause, or if it fits in sepsis 3 definition there where there is a organ dysfunction along with clinical suspicion infection, you have to start the antibiotic as per your antibiogram of the hospital bug or hospital antibiotic policy and according to the suspected source of infection where you suspect the infection a site of action. If you are strongly clear that there is probably a non-infectious cause, you may afford to wait, and depending on the clinical context, you have to reevaluate after 48 hours. Masterly inactivity and rather than starting unnecessary antibiotic will be useful in such situation. If you are suspecting that despite broad spectrum antibiotic, your patient's persistent fever and he fits in the clinical context where he may be a high risk for fungal infection, you consider fungemia in this patient to be localized, colonized by fungus, and you can start antifungal in such situation. What to do after 48 hours? 48 hours if the fever persists and no source identified despite empirical antibiotic, there is a clinical context. As I told, you should cover for antifungal Candida auris. Or if you suspect non-infectious cause, then you go for the venous Doppler, do the differential count. Sometimes eosinophilia will point to a drug fever, whether you started this drug in the last 24 hours and you stop that drug and the fever is gone. So this re-evaluation is very important step during the course of managing the fever in the ICU. Now coming to the algorithm approach, I suggest the clinical driven approach, but this is handy bedside. If you confirm the fever more than 38.3, 100 degree centigrade, what is the next step? Next step is to do the focused clinical examination, as I told, chart review, talk with the sister, anything new drug introduced, any manipulation of the line done, any blood products being given, any patient was exposed to the dye or he underwent dialysis, or you get the review of the days of catheter, how many days the indwelling catheter is in situ, and that is the rapid sepsis screening from head to toe. Suppose you have a clinical suspicion as a source of infection, the appropriate investigation according to that. You're suspecting WAP, you go for the chest X-ray. In such situation, you have to send two blood culture. Exception is immunocompromised patient. If there is sepsis, hypotension, no new organ dysfunction, go for the blood culture anaerobic, aerobic, according guided by your microbiology department. Adequate sampling is important. If there is no obvious source and still you suspect suspicion and the line was put in emergency, you have to remove this, get rid of this line as a catheter. If there is persistent fever on broad spectrum antibiotics, you can suspect either a non-infectious cause. Then you send the serum procalcitonin and CRP, which has a negative predictive value, and you can look in for the drugs for the SA, like central causes of fever, or there is a thrombophlebitis or DVT or pulmonary embolism or fibrillatory phase of ARDS. If you have occult source of sepsis suspected, you go for CECT, thorax, USG, and PET scan will be handy in such situation. And if there are risk factors, as I told, you suspect immunocompromise, you suspect fungal colonization, fungal culture, and fungemia, you should go for the antifungal treatment. So most of this algorithm will help you to bedside approach, but it should be clinical driven. Thank you very much.